Good afternoon, ladies and gentlemen, dear colleagues. Thank you very much for inviting me here. I'd like to talk to you about the contrast, sometimes contradiction, between professionally delivered healthcare and industrial healthcare, and try to give elements to answer the question whether patients, physicians, and the pharmaceutical industry's interests are or not converging. So I'm going to talk about the implications of professionally delivered care and the interests of the patients and the patients' organizations, the interests of the physicians and the physicians' organizations, and their common ground, in particular with regard to health systems' requirements for professionally delivered healthcare. Then I'm going to talk about care industrialization, its origins and impact, then the consequences for health policies, and I will discuss whether other industries should join them, and in particular, why the pharmaceutical industry would be advised and well advised to join the club. These are the components of healthcare seen from a quality perspective, and I guess that all of us, we've been patients, we or beloved were patients at one stage or another, and in dark blue, you see the evidence-based medicine, and that's the scientific part of the good medical practice. But then we have other components that cannot be standardized, like manual skills and behavioral skills, ethics, complex decision-making related in particular to biopsychosocial care. We all want that, especially our family doctors are supposed to give us that. And then reflexivity. We want doctors who lifelong learn from their mistakes. These are unavoidable, but there are systems whereby we can increase the learning from our mistakes, and other systems who simply ignore it. Now, apparently, evidence-based is the most standardizable part of medical practice. However, it only permits a degree of standardization and requires, clinical decision-making requires a sufficient degree of autonomy in interpreting standard operating procedures, guidelines. And I recommend you to read the paper in the British Medical Journal by Trisha Greenhalgh and colleagues over the crisis of the evidence-based medicine movement. Furthermore, patients and patients' organizations need accessing health care in universal health pyramids, in universal health systems. Family medicine, because it solves 90% of health problems, because it's close to patients' homes, because it provides biopsychosocial care, and by the way, today epigenetics support the importance of family medicine and biopsychosocial care. And finally, with community medicine, especially in low and middle income countries, we have a powerful social stabilizer. Now, people also need hospital care, from general hospitals to university teaching hospitals, because they treat those who are most at risk of dying, and because hospitals support first-line services, in particular with evaluation and continuous medical education. Now, why do physicians and physicians' organizations benefit from professionally delivered healthcare? First, because their income increases with qualification. Second, because money is not everything in life, and symbolic motivation has an existential importance for us doctors. It encompasses professional identity, the social mission of our work and social recognition, use of knowledge and communication to solve problems, and teamwork is important for our pleasure to work as well. Now, if we recognize the importance of professionally delivered healthcare for patients and doctors, we need to reconsider the design of health systems. Basically, health services should provide individual, technical, and psychological coaching to health professionals, which they rarely do actually, disseminate biopsychosocial care, and we have strategies for that, steer Hippocratic or Ayurvedic in other places medical practice, promote reflective techniques. These are the techniques that enable us to learn from our mistakes. Then frame and limit care standardization and guarantee a sufficient degree of professional autonomy, and motivate professionals not only with material income, but also with symbolic incentives, and this is rarely done by health systems, even in Europe. Finally, health services should be organized in networks with systemic features in the management, permitting information, clinical and managerial coordination. Let's go to the care industrialization, its origins and its consequences. Commoditization of health financing is achieved through commercial insurances, private investments and public-private partnerships in health financing, purchaser-provider split, and contracting out the management of public health finances, one of the most advanced countries in this process being Colombia and Mexico. Then the insurances take control of hospitals, health facilities in general, and medical practice, and impose, some will see that in a moment, an important degree of standardization. Finally, public insurances remain for the non-profitable segments of the population only, namely the poor, as per Medicaid in the United States, and the elderly, as with Medicare. In the developing countries, public services are limited to disease control and to epidemiological surveillance. Now, the impact has been the following. To control cost, care financiers tend to over-standardize clinical decision making in the name of science and evidence-based medicine, which, by the way, I certainly do not reject. The issue of evidence in medicine is obviously something quite fundamental for progress. But this over-standardization has had consequences for management, research, and teaching in addition to quality of care. Besides, commercial insurances ration referrals to higher complexity medical care, and with regard to medical practice, reduce professional autonomy and steer clinical task shifting to non-physicians. The consequences are, as in the US, a reduction in access to quality health care and skyrocketing costs. Now, if we want such health systems, these have consequences for the design of health policies. And I think that there could be an agreement between patients' organizations and mutual aid associations on the one hand and physicians' organizations on the other in order to reshuffle European health systems, to modify international cooperation so as to promote access to individual health care in Africa, Asia, and Latin America, just as we want it for us and our family in Europe, and refrain from undermining access to health care under the false flag of disease control. A third consequence, and I hope to convince you today of its importance for the pharmaceutical industry in Europe, is that Europe should not sign the TTIP and TISA treaties because they will deregulate healthcare financing and drastically constrain social protection. Now, let's see the reasons why. First, in general, European industries will lose a lot by signing these treaties and adopting a system of industrialized care delivery. You have here on the screen the evolution of health expenditure, total health expenditure from 1980 to 2010. And here you have the United States. Today, in the US, they spend about $8,000 per year per inhabitant compared to $4,000 on an average in Europe. That's twice of it. Look at those countries in Europe that have adopted the same system as in the United States. The Netherlands is a good example. I come from Belgium, they are our neighbors, and I know the system relatively well. When they started here in 2003, the privatization of healthcare financing, total health expenditure started skyrocketing, and now they are at the level of Switzerland, which also has private health insurances. Now, why do I say that the European industry has absolutely no interest in such an evolution? This is the blue pie plus the red pie is the European GDP in 2000. And the red share of health expenditure represented 7.9. As you know, since then we have had 1.1 or 1.2 growth rate in Europe, so that the pie today, or in 2011, was roughly speaking the same, with a slight increase in health expenditure up to 9%. Now, if we project from 11 years on later, and we make a simulation looking forward to 2022, we will have, roughly speaking, the same size, the same pie. But if we sign the TTIP, instead of 9%, we have good reasons to believe that we will have, like in the United States, 18% of health expenditure. And those who are not investing in health, all the other industries are likely to lose a lot, but they don't know. Now I would like to finish this presentation by telling you, because many of you are working in the pharmaceutical industries, why your interest is exactly the same as the other European industries. The data I'm going to give you are, say, conceived not just to instill a doubt. I don't want to convince you. I would like rather to convince you to reconsider market studies. And the classical market factors in pharmaceutical industry revenues are the export of drugs, country GDP, health expenditure on healthcare expenditure per capita, the proportion of out-of-pocket expenditure, the government control of market and prices, and prescription patterns. Now, look at the following paradoxes. Here you have the pharmaceutical revenues as a percentage of health expenditure in 2013 in a series of Latin American countries. If you consider those countries with a red arrow there, I'm talking about Peru, Mexico, Dominican Republic, Colombia, and I could even add Brazil and Chile, you have a lot of private insurances. These are the countries where the pharmaceutical industry is earning the less. Instead, in countries like Cuba, Costa Rica, Argentina, the proportion is much higher. Now, I would like you to go to OECD countries. Before that, if you want to understand this classification of countries with regard to the revenues of your industries, these are the features that need to be scrutinized. How sufficient is access to family medicine and hospitals? It's obvious that you sell less drugs where access to care is not sufficient. Second, who manages government expenditure on health? In Colombia, private interest manage it?
Okay.
How do Bismarckian versus Bavarian financing impact on pharmaceutical markets? How important is the insurance market versus social financing sector? And how is the structure of public services? Now, let's go to Europe and OECD countries. And in particular, let's consider the financial spending as a proportion of total health spending. Here you have you have from left to right, the Netherlands, Switzerland, and the United States. And as you can see, it's not far from half of the same proportion in Spain. The reasons are related to, first, poor access to care. There is a tremendous difference amongst all these countries in terms of access to care. And if you look, for instance, here you have OECD data. If you look at the access of the rich in the United States, well, actually, it's worse than the access of the poor in many European countries. It's worse than in countries like Canada, France, Sweden, etc. And there is a second reason why you should consider twice the importance of private health insurances. The Kiwi regulation. New Zealand used to have a law whereby the government and the social protection would only reimburse those drugs that were the most efficient. At one stage, there was an attempt to do that in Belgium. It failed. Now, in the United States, when you have an HMO and a private insurance, they are capable of imposing the selection of one drug in all their network. These may be reasons that have not been sufficiently been scrutinized while considering the importance of the different health systems patterns for the nature and the importance of the drugs markets. In conclusion, patients and professionals have a joint interest in health policies that are geared to secure access to professionally delivered health care in universal health systems. Patients and professionals have a powerful leverage to prevent commoditization of healthcare financing, and I hope to have convinced you that the industry in general, and in particular the pharmaceutical industries, may want to join their club because of access to care and because of profitability when care is professionally delivered, and finally, because of bargain conditions with HMOs and health insurances. Thank you.